Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the neurology, that is the motor neuron disease. So, if you see the basic introduction of the motor neuron disease, it is the disorder of the motor neurons, right? That means only motor neurons are being affected in case of the motor neuron disease. That means there is no sensory manifestations in patients with the motor neuron disease. And if you take the age group at which commonly you see this motor neuron disease, that is in between 30 and 60 years of age, right? So that is in between 30 and 60 years of age, very commonly you see this motor neuron disease. And what are these particular motor neurons? What happens to these motor neurons? See, the motor neurons we have within the spinal cord and the motor neurons we have within the brainstem as well. So, the motor neurons within the spinal cord, they are the anterior horn cells. Right, the motor neurons in the spinal cord, they are the anterior horn cells, whereas within the brainstem we have the motor nuclei of the lower cranial nerves. Right, within the brainstem we have motor nuclei of lower cranial nerves. So, whenever there is degeneration of the anterior horn cell or whenever there is degeneration of the motor nuclei of the lower cranial nerves, that will make the individual to develop what is called the motor neuron disease. So, what happens to these motor neurons? There will be degeneration of these particular motor neurons. Okay, now, and what will be the tracts which are being affected? All that we will be discussing. But I just want to say you in this slide, the motor neurons like anterior horn cells of the spinal cord and motor nuclei of the lower cranial nerves, they are being affected. And next you need to know what is the important risk factor for the development of the motor neuron disease. It is cigarette smoking. It is a very important risk factor. Right, cigarette smoking, it is a very important risk factor for the development of the motor neuron disease. Then followed by that, you see this important question, which is pathognomic for the motor neuron disease? Fasciculation, bladder bowel involvement, pseudohypertrophy, sensory loss in the patchy manner. So the pathognomic of the motor neuron disease, let me tell you the answer here itself and then I'll discuss in detail. The pathognomic of motor neuron disease is the development of the fasciculations. Now, you need to know these particular motor neurons. See, in motor neuron disease, there is degeneration of the motor neurons. Now, this particular motor neurons, right, they include either upper motor neuron or the lower motor neuron. Right, it is either upper motor neuron or lower motor neuron, or the motor neurons which will be degenerated is the both. So either of these, so either there is degeneration of upper motor neurons or degeneration of the lower motor neurons or degeneration of both upper and as well as the lower motor neurons. And the severity of involvement of the upper motor neuron and lower motor neuron is completely variable. And as I have said you previously also, in motor neuron disease, the neurological deficit is purely motor, right? Please remember this very important point, that in case of motor neuron disease, there is no sensory involvement. Right? There is no sensory involvement in patients with the motor neuron disease. Then, followed by that, you need to know that motor neuron disease is characterized by the involvement of, I said you already, either upper motor neuron or lower motor neuron. Now, what is that upper motor neuron which is being affected? The upper motor neuron which is being affected includes either corticospinal tract, right, either corticospinal tract within the spinal cord, or the upper motor neuron which is being affected is corticobulbar tract, right, corticobulbar tract within the brain. Okay, that is the upper motor neuron which is being affected, and the lower motor neuron which is being affected is either anterior horn cells of spinal cord, right, either anterior horn cells of the spinal cord, that is the lower motor neuron within the spinal cord, or there is involvement of the cranial nerve nuclei within the brainstem. Right, there is involvement of the cranial nerve nuclei in the brainstem. That is about the lower motor neuron involvement, or there can be involvement of these both, right, or there can be involvement of both upper motor neuron and as well as the lower motor neuron. So that is what exactly happens in the motor neuron disease. Now, why does this happen? Why there is the motor neuron degeneration in patients with the motor neuron disease? So that is due to impaired neuronal viability. So that impaired neuronal viability, it is due to, right, it is due to mutation of superoxide dismutase 1 transgenes. Okay, impaired viability due to superoxide dismutase 1 transgenes. So this will be the gene which is being mutated in case of motor neuron disease, and because of which there is impaired neuronal viability. Now, what is this particular type of mutation? That is hexanucleotide repeat. Okay, the type of mutation is right, the type of mutation is the hexanucleotide repeats, and this hexanucleotide repeats will lead to overexpression of the excitatory neurotransmitter. Okay, so this leads to overexpression of excitatory neurotransmitter, that is glutamate. Okay, so there will be excessive release of the glutamate in patients with this motor neuron disease, and this glutamate is the one which is responsible for free radical damage of the neurons. Right, which is responsible for free radical damage of the neurons. Okay, so that is what exactly is the abnormality in the motor neuron disease. So there is impaired neuronal viability due to superoxide dismutase 1 transgenes, and the type of mutation is the hexanucleotide repeat, and this leads to overexpression of excitatory neurotransmitter, that is glutamate, which will cause the free radical damage of the neurons. Okay, right, followed by this you need to know that the clinical spectrum of the motor neuron disease. So I said you, in case of motor neuron disease, either there is involvement of lower motor neuron, or there is involvement of upper motor neuron, or there is involvement of the both. Now if you see the disorder where there is predominantly involvement of the lower motor neuron, that particular disorder, it is spinomuscular atrophy. right? That particular disorder is spinomuscular atrophy, right? Where there is degeneration of the anterior horn cells. Right, where there is degeneration of the anterior horn cells, or there can be predominantly upper motor neuron involvement, and this predominantly upper motor neuron involvement, what is that particular disorder? That is your primary lateral sclerosis, right? Primary lateral sclerosis. And here, what is that upper motor neuron which is being affected predominantly? That is corticospinal tract. Right, that is the corticospinal tract. So that is what is the only upper motor neuron which is being affected, and you have the involvement of both, that is involvement of upper motor neuron and as well as the involvement of the lower motor neuron. Okay, that means upper motor neuron involvement is your corticospinal tract and lower motor neuron involvement is your anterior horn cell. And what is that particular disorder? That will be amyotrophic lateral sclerosis. Right, ALS stands for amyotrophic lateral sclerosis. So among these three motor neuron diseases, that is spinomuscular atrophy, primary lateral sclerosis and amyotrophic lateral sclerosis, let me tell you, it is your amyotrophic lateral sclerosis that is the most common type of the motor neuron disease. Right, now then, so this is the clinical spectrum. Now the next important thing is the clinical manifestations of the motor neuron disease. The manifestations, they are completely variable, right? They are completely variable depending upon the predominant involvement of the various neurons. That means either there is involvement of only lower motor neuron, as we see in case of spinomuscular atrophy, or there is only involvement of upper motor neuron, that is in case of primary lateral sclerosis, or there is involvement of both, that is amyotrophic lateral sclerosis. Now, for suppose if there is involvement of only lower motor neuron, what will be the manifestations? So, what will be the features? Due to anterior horn cell involvement, lower motor neurons also we have at two places. One lower motor neuron, it is present in the spinal cord. And what is that particular lower motor neuron? That will be the anterior horn cell. And another important lower motor neuron that is present in the brainstem. And the name of that particular lower motor neuron, it is the brainstem nuclei. Right, that is your brainstem nuclei. Now, what will be the features due to anterior horn cell involvement, which is a lower motor neuron? There will be asymmetrical paralysis. Right, there will be asymmetrical paralysis initially, then followed by that there will be fasciculations, and these fasciculations are pathognomic of the motor neuron disease, and then followed by that there is progressive muscular atrophy. Right, there is progressive muscular atrophy. So these will be the features of the anterior horn cell involvement. Now you take these fasciculations. See, how do you describe these fasciculations? Fasciculations, they are the involuntary movements due to contraction of the single muscle fiber. I'll repeat the point again. Fasciculations are the involuntary movements that you will observe due to contraction of the single muscle fiber, that is called fasciculations, and that will be there due to the involvement of the anterior horn cell. Then you see the features due to the brainstem nuclei involvement. Due to brainstem nuclei involvement, you have the development of the bulbar manifestations, and that bulbar manifestations include, there will be difficulty in chewing, right, there will be difficulty in chewing, Why is that? That is due to involvement of the muscles of mastication. What are those muscles of mastication? That includes medial pterygoid, lateral pterygoid, temporalis muscle, and as well as the masseter muscle. And there is also difficulty in swallowing. Right, and why is that there is difficulty in swallowing? That is due to involvement of the pharyngeal muscles, and due to which there will be dysphagia. And there is difficulty in movement of the face. And why is that there is difficulty in movement of the face? That is because of the involvement of the facial muscles. Right, that is because of the involvement of the facial muscles. And these facial muscles, once they develop weakness because of the facial nerve nuclei involvement, there will be difficulty in the movement of the face, and there is also difficulty in the movement of the tongue. Right, and why is that? That is because of the involvement of the 12th cranial nerve nuclei. 12th cranial nerve nuclei is a motor nuclei to the tongue, and because of the 12th cranial nerve nuclei, the individual will have difficulty in movement of the tongue. And not only that, on the tongue, you will also observe the presence of the fasciculations. Right, you will also observe the presence of fasciculations over the tongue. So that is about the lower motor neuron involvement clinical manifestations. Then followed by that, what will be the upper motor neuron manifestations? See, the upper motor neuron which is being affected is either corticospinal tract, which is present within the spinal cord, right, or there can be involvement of the corticobulbar tract, right, which is present within the brainstem. Right, which is present within the brainstem. So these are the upper motor neurons which are being affected, and due to the involvement of the corticospinal tract, there will be exaggerated deep tendon reflexes. Right, the deep tendon reflexes, they become hyperactive, and there will be increase in the tone of the muscles, and that we call it as, right, that we call it as spasticity, right, which is nothing but hypertonia. And the next thing is corticobulbar tract involvement. Corticobulbar tract, it is nothing but the upper motor neuron at the level of the brain. And because of the corticobulbar tract involvement, the individual will develop what is called pseudobulbar manifestations. See, the cranial nerve nuclei involvement, that will be lower motor neuron, the individual will have bulbar manifestations. But corticobulbar projection innervating the brainstem, that will be the upper motor neuron, the individual will have pseudobulbar manifestations, and that includes exaggeration of the exaggeration of motor expressions of emotion. Right, exaggeration of motor expression of emotions. Now, what are the emotions which gets exaggerated? That there will be increased laughing and increased weeping, that is crying. Okay, this is one point. And second important thing is there can be exaggerated jaw jerk. Right, there can be exaggerated jaw jerk, and there will be dysarthria. And what do you understand by this word dysarthria? That is difficulty in articulation of the speech, and that is also because of the involvement of corticobulbar tract. So all these, they are the pseudobulbar manifestations. Bulbar manifestations is lower motor neuron involvement. Pseudobulbar manifestations, they are upper motor neuron involvement within the brain. Now, followed by that, you see this terminology spasticity, which is an upper motor neuron manifestation. We have two terminologies. One is spasticity, the other one is rigidity. What is the difference between these two? Both of them, let me tell you, it is due to upper motor neuron involvement only. Right, both of them, they are due to upper motor neuron involvement only. Whereas if you take spasticity, the upper motor neuron which is being affected is pyramidal tract. Right, the upper motor neuron which is being affected is the pyramidal tract, and that pyramidal tract involvement is corticospinal tract. And if you see the tone, it is increased, but the tone which is increased, it is velocity dependent. Right, this is velocity dependent. What do you mean by the word velocity dependent? See, once you increase or once you do passive movements, and if you increase the velocity of these passive movements, the tone increases. That is what is your spasticity. It is velocity dependent. Whereas here rigidity, if you see, even that is also due to upper motor neuron involvement, but it is the extra pyramidal tract involvement. Right, that will be extra pyramidal tract involvement. Okay, and that extra pyramidal tract lesion, that includes the rubrospinal or vestibulospinal tract involvement. And please remember, the rigidity, it is not velocity dependent. Right, it is not velocity dependent. And what do you mean by the word it is not velocity dependent? It is the one which does not vary with the speed of movement. Okay, does not vary with the speed of movement. Right, does not vary with the speed of the movement of the muscle groups which are involved. That is called not velocity dependent, whereas spasticity, it is velocity dependent. Right, and it is this spasticity, it is most noticeable with fast movements. Right, it is most noticeable with fast movements. Which one? The spasticity. Whereas rigidity, it is not velocity dependent and does not vary with the speed of the movement of muscle groups which are involved. So that is about the differences between the spasticity and as well as the rigidity. And remember this important point, the motor neuron involvement in motor neuron disease is not only limited to motor neurons if spinal cord, but they also involve the motor neurons of the brain stem as well. So motor neurons of the spinal cord and motor neurons of the brain stem are also being affected. And in the brain stem, what is the upper motor neuron? The part which is above the brain stem will be the upper motor neuron, which is nothing but the corticobulbar tract, whereas the cranial nerve and as well as the cranial nerve nuclei will be the lower motor neuron. Now, apart from these, what are the other manifestations of motor neuron disease? So one, we have discussed the manifestations of lower motor neuron disease, both at the level of the anterior horn cell and at the level of cranial nerve nuclei. And two, we have discussed about the upper motor neuron involvement, right? That is the involvement at the level of the spinal cord and involvement at the level of the corticobulbar tract. And the other features of motor neuron disease is that there is no bladder and bowel involvement in motor neuron disease. Right, there is no bladder and bowel involvement in motor neuron disease. Please remember, that's a very, very important point. And as I have said you previously also, in motor neuron disease, the neurological deficit, it is purely motor. Right, the neurological deficit, that is purely motor. And please remember, there is no sensory loss. Right, there is no sensory loss. Okay, there is no sensory involvement. And the next important point is, there is no pseudo hypertrophy of the muscles. Right, there is no pseudo hypertrophy of the muscles, rather there will be progressive muscular atrophy which is seen. Right, so what is that you will observe? There will be progressive muscular atrophy which is seen in patients with the motor neuron disease. And what about the ocular motility? The ocular motility of the individual, it is spared. Right, the ocular motility is spared. And what about the higher mental functions? The higher mental functions, they are absolutely normal. Right, the higher mental functions, they are absolutely normal in patients with the motor neuron disease. And what will be the most common symptom? The most common symptom in case of motor neuron disease will be fasciculations. So this fasciculations, you know, they are pathognomic of the motor neuron disease. So these are the other features of the motor neuron disease. And if the question is asked, what is the most common cause of death in patients with motor neuron disease? That is respiratory failure. And what type of respiratory failure? That will be type 2 respiratory failure. Right, that will be type 2 respiratory failure. And type 2 respiratory failure is that which is characterized by hypoxia and as well as the hypercapnia. Right, there will be hypoxia and as well as the hypercapnia. That is what you will observe in case of the motor neuron disease. That is your type 2 respiratory failure. Next, you see this question now, which is pathognomic for motor neuron disease, that is fasciculations. And what about bladder and bowel involvement? There is no bladder and bowel involvement at all. And there is no pseudo hypertrophy of the muscle, rather there is progressive atrophy of the muscles. And sensory loss will occur in patchy manner, that is false statement. Right, sensory loss does not occur in these patients with the motor neuron disease. Now, followed by that, the next important thing, you see a clinical question. A middle-aged man presents with the progressive atrophy and weakness of hands and forearms. On examination, he is found to have spasticity of the legs, generalized hyperreflexia, increased signal in corticospinal tract on T2 weighted MRI. What is the most likely diagnosis in these patients? Fasciculations, bladder and bowel involvement, pseudo hypertrophy, sensory loss in the patchy manner. Now, what is this clinical scenario suggestive of? This particular clinical scenario, it is suggestive of amyotrophic lateral sclerosis. Now, why are you considering, right? Why are you considering it to be an amyotrophic lateral sclerosis? Why? Because this patient has both upper motor neuron involvement as well as the lower motor neuron involvement. Right? This patient has both upper motor neuron and as well as the lower motor neuron involvement. Okay. Now, the upper motor neuron involvement features, if you observe, that includes spasticity of the leg, right, which is an upper motor neuron involvement. Then generalized hyperreflexia, that is increased deep tendon reflexes. That is also the features of the corticospinal tract involvement. So these are your upper motor neuron manifestations. Whereas if you take the progressive atrophy of the hands and as well as the forearms, that will be the lower motor neuron manifestation. So the patient has both upper motor neuron and as well as lower motor neuron manifestations. So what is that? It will be, it is the amyotrophic lateral sclerosis. And in amyotrophic lateral sclerosis, what will be the characteristic manifestations? That will be fasciculations, right? That will be fasciculations, and it is suggestive of amyotrophic lateral sclerosis, right? So yeah, so that was a case of amyotrophic lateral sclerosis, and the important manifestation will be the fasciculations, right? Next, then followed by that, how will you diagnose this motor neuron disease? See, there are multiple methods by which you can diagnose this motor neuron disease. One among that is MRI, electromyography, and creatinine kinase levels, and certain blood investigations. Now you take the electromyography. Electromyography, it may show the signs of acute and chronic partial denervation with reinnervation. Okay, so electromyography, this will show this will show acute and as well as chronic partial denervation with reinnervation. That is what the electromyography shows. And in patients with suspected amyotrophic lateral sclerosis, the diagnosis should not be made with confidence unless such changes are found in at least 3 spinal regions. Okay, so these electromyographic changes should be there in at least 3 spinal regions. And what are those 3 spinal regions? That includes cervical, thoracic, and then lumbosacral. So in these 3 spinal regions, you should have the signs of acute and chronic partial denervation with reinnervation. And if you take the motor conduction velocity, this is usually normal, right? Motor conduction velocity is usually normal, but it may slightly get reduced, right? May slightly get reduced. And sensory conduction studies are also, they are absolutely normal, but these motor conduction velocities, they may be normal or they may be slightly reduced. And about the sensory conduction abnormalities or sensory conduction studies, so sensory conduction studies, if you see, they will be absolutely normal in the electromyography. Next, then followed by that, the biopsy. So if you take this biopsy of a wasted muscle, that will show the histological changes of denervation, right? If you take the biopsy of a wasted muscle, that will show the histological changes of deinnervation or denervation. But let me tell you, even though the wasted muscle shows the histological changes of denervation, but it is not necessary for the diagnosis. Right? It is not necessary for the diagnosis. Okay? Please remember, it's a very, very important point. Next. Then followed by that, the next important investigation is the serum creatinine kinase levels. The serum creatinine kinase, they may be slightly elevated. Right? They may be slightly elevated, but never reaches the extremely high values seen in some of the muscular dystrophies. So, if you see in certain muscular dystrophies, the serum creatinine kinase levels, they are extremely high. Right? They are extremely high. But the increase in serum creatinine kinase, which you see in case of motor neuron disease, they never reach the extremely high what you see in case of muscular dystrophy. And if you take the CSF, cerebrospinal fluid examination, this will be absolutely normal. Then, followed by that, we have a form of motor neuron disease that is called as the spinomuscular atrophy. And in this spinomuscular atrophy, it is only lower motor neurons which are being degenerated. Right? It is only the lower motor neurons which are degenerated. And to diagnose this spinomuscular atrophy, molecular genetic testing for pathogenic variants is available. So you need to do molecular genetic testing. And this molecular genetic testing should be done for pathogenic variants of SMN1. So, the pathogenic variants of SMN1, it is available. That is to diagnose the spinomuscular atrophy, right? And if you take the biopsy, right, I said you, biopsy of the wasted muscle, you can observe the histological changes of denervation. And there are certain abnormal findings on rectal biopsy as well. And what are these abnormal findings on rectal biopsy? That includes, right, that includes reduced hexosaminidase A in the serum. Right, that includes reduced hexosaminidase A levels, both in the serum and as well as the leukocytes, right? So that will be the rectal biopsy picture. Next, followed by that, the another important okay, you see this question now. A patient aged 45 years or a middle-aged man presented with progressive atrophy and weakness of hands and forearms. On examination, he is found to have slight spasticity of the legs, generalized hyperreflexia, increased signal in corticospinal tract on T2 weighted MRI. What is the most likely diagnosis? The same question we have discussed just now. But in that question, the options were in the form of the clinical manifestations and examination finding. That was fasciculations. And what is the diagnosis? That is amyotrophic lateral sclerosis. So, the another important method by which you can diagnose this amyotrophic lateral sclerosis, that is by your axial T2 weighted MRI. So, when you do an axial when you do an axial T2 weighted MRI scan through the lateral ventricles, when you do an axial T2 weighted MRI through the lateral ventricles of the brain, that will reveal abnormal high signal intensity within the corticospinal tract, right? That will reveal abnormal high signal intensity in corticospinal tract. That is what you will observe in axial T2 weighted MRI. So these will be the investigations now. So number one, your electromyography. Electromyography will show you the acute and chronic partial denervation with reinnervation. And in patients in whom you are suspecting amyotrophic lateral sclerosis, the diagnosis should not be made with confidence unless such changes of denervation with reinnervation are present in at least 3 spinal regions, that is cervical, thoracic and lumbosacral regions, right? And the motor conduction velocity is usually normal but may be slightly reduced, and sensory conduction studies are also normal. Then followed by that, the biopsy. Biopsy of the wasted muscle, if you see, that will show the histological changes of denervation, but it is not necessary for the diagnosis. And serum creatinine kinase levels, they are slightly raised. And how will you diagnose spinomuscular atrophy? That is by molecular genetic testing for pathogenic variants of SMN1 is available. And rectal biopsy is also the one which will show you the abnormality. And in serum and as well as WBC, right, in serum and as well as WBC, you have reduced hexosaminidase A levels in these patients with the spinomuscular atrophy. Then how will you treat these patients, right? Coming to the treatment. As such, there is no curative medical treatment, right? So you need to just give only supportive therapy. That includes walking aids, right? That is walking support. Then wheelchair, and as well as the physiotherapy. Right? So this will be the treatment initiatives. As such, there is no specific drug that you can give, but these are the supporting treatment strategies for the motor neuron disease. And if you take the respiratory care, I said you that these patients, the cause of death is respiratory failure, and in the later stages of the disease there is involvement of the respiratory muscles, for which you need to put the patient on non-invasive ventilator, right, for which you need to put the patient on non-invasive ventilator. So this non-invasive ventilator, it is used at night, and studies have shown a survival benefit of around 7 months. Okay, so the studies have shown, so with the use of non-invasive ventilator, survival benefit it is around 7 months, right? And this non-invasive ventilator should be placed to the individual for at least 4 hours per day, right? Should be placed at least 4 hours per day, and in patients with a maximal inspiratory pressure less than 60 centimeters of water. So when you place this NIV for 4 hours per day, that can improve or prolong the survival of these patients with the amyotrophic lateral sclerosis. And sometimes, tracheostomy is performed in severely affected individuals. Right, in severely affected individuals, tracheostomy is sometimes performed. Right, tracheostomy is sometimes performed. When is that? When the respiratory muscles are severely affected. That is the point when you need to put the patient on the endotracheal tube, and ultimately they require the tracheostomy. Particularly in the terminal stages of these disease, you need to put the patient on the tracheostomy. Then followed by the respiratory care. How is that you will do the symptomatic treatment? See, symptomatic and supportive measures to treat spasticity, drooling, dysphagia, and to preserve the mobility. How is that we will do? Let me explain you, right? So for the drooling, right? So for the drooling of the saliva in these individuals, you need to give over the counter decongestants, right? Over the counter decongestants. Then the anticholinergic drugs which will reduce the salivary secretions. Right? And these particular anticholinergic medications, they include trihexyphenidyl, right? That includes trihexyphenidyl, which is an anticholinergic drug. Then amitriptyline and as well as the atropine, right? Amitriptyline, it is a tricyclic antidepressant, right? It is a tricyclic antidepressant. Then apart from these which will help in controlling the drooling, the other important thing is the botulinum toxin injections into the salivary gland. Right, botulinum toxin injection into the salivary gland, right? So if you inject this, then the drooling can get reduced. So this is how you need to do symptomatic treatment for drooling. Then followed by that, how is that you will do the symptomatic treatment of the pseudobulbar effect? Pseudobulbar effect, it includes dysarthria, exaggerated emotions, and there can be even dysphagia. So for that, for relieving the pseudobulbar effect, you need to give a combination of dextromethorphan and quinidine, right? You need to give combination of dextromethorphan or quinidine should be given, right? And what will be the dosages of these the quinidine? Either you give 20 milligrams or 10 milligrams, one tablet orally once or twice daily has to be given. So this combination you need to give one tablet. The route of administration will be the oral route of administration, and you give this once daily or the twice daily, and this will relieve the symptoms of the pseudobulbar effect. Next, then followed by that, for suppose if the dysphagia is very severe, then how will you treat? You need to supplement a semi-liquid diet or you need to put gastrostomy tube. Right, you need to put the gastrostomy tube feeding. Right, so these may be needed if dysphagia is severe, and it is advisable to perform the procedure before the forced vital capacity falls below 50%. Right, so you have to do this before the forced vital capacity falls to less than 50% of the predicted value. That is the point when you need to do this gastrostomy tube feeding. When is that you should do? That is when if the dysphagia is severe. Then how is that you will treat the spasticity? So if you take the treatment of spasticity, you need to give baclofen or you need to give tizanidine. Right, baclofen or tizanidine should be given for the treatment of spasticity. And how is that you will treat the depression? That is, you need to supplement selective serotonin reuptake inhibitors. So this will be the symptomatic treatment in case of the motor neuron disease. So in case of the respiratory care, you need to put the patient on non-invasive ventilator, and in severe muscular weakness, you need to put the patient on the tracheostomy. And for pseudobulbar effect, you need to give combination of dextromethorphan or the quinidine should be given. And for drooling, you need to give the botulinum toxin injection into the salivary glands or over-the-counter decongestants or anticholinergic medication are useful. That is to reduce the drooling. Then how is that you will control dysphagia? If dysphagia is severe, you need to give a semi-liquid diet or gastrostomy tube feeding may be needed if dysphagia is severe. But remember, all this gastrostomy tube procedure should be done before the forced vital capacity falls below 50% of the predicted value. And how is that you will treat spasticity? That is by giving baclofen or the tizanidine. And depression should be treated by the selective serotonin reuptake inhibitors. Next, we have few drugs which will improve the survival of the individual with motor neuron disease, particularly amyotrophic lateral sclerosis. And one particular drug is riluzole. Okay, so what this riluzole will do is will improve survival of the individuals with amyotrophic lateral sclerosis. And what is the dosage of the riluzole for amyotrophic lateral sclerosis? You need to give 50 milligrams orally, and you have to give this twice daily. And what is the mechanism of action of this riluzole? The mechanism of action of riluzole is that it will reduce the presynaptic release of glutamate. Right, it will reduce presynaptic release of the glutamate. See, in the pathophysiology we have discussed there is excessive release of glutamate causing free radical injury, causing the free radical release causing degeneration of the motor neurons. And whenever you give this riluzole, this will reduce the presynaptic release of the glutamate, and thereby there will be increased short-term survival in amyotrophic lateral sclerosis patient. Right? The only drug that has a modest effect on survival is riluzole. And what exactly is this? It is a sodium channel blocker. Right? It is a sodium channel blocker that will inhibit the glutamate release. So that is about the riluzole. The next important drug like what we have is the edaravone. Edaravone, it is a free radical scavenger. So what is that we have discussed? That there will be release of glutamate in excess quantity because of the gene mutation, and that glutamate whichever is released will cause the free radical release. And this free radicals is the one which will cause the degeneration of the motor neurons. Okay, so your edaravone, it is a free radical scavenger, and this edaravone, it will slow the disease progression in patients with mild disease. right? This will slow the disease progression. In patients with mild disease. And how is it administered? It is administered in monthly cycles as a 60 milligrams intravenous infusion. Right, 60 milligrams intravenous infusion on days 1 to 14 in the first month and days 1 to 10 in the subsequent months. Right, the dosage is 60 milligrams intravenous infusion. So that is about the edaravone. Next, if you see the treatment of spinomuscular atrophy particularly, treatment of spinomuscular atrophy takes advantage of fact that SMN protein is also encoded by a second gene, that is SMN2. So basically in spinomuscular atrophy, it is the problem in the SMN protein. That is what I have discussed in the beginning also. Okay, so the treatment of spinomuscular atrophy takes advantage of the fact that SMN protein is also encoded by a second gene, that is SMN2, that usually does not translate functional protein due to aberrant splicing. Now, what is the drug that you will give for spinal muscular atrophy? We have a new drug, and that particular new drug is nusinersen. Right, nusinersen. Nusinersen, it is an antisense oligonucleotide. Right, it is an antisense oligonucleotide. And what this will do? This will improve the reinnervation into the muscles, and thereby it can improve the survival of the individual. So nusinersen, it's a new drug or a new molecule for the treatment of the spinal muscular atrophy, right? And this is approved for use in all ages. And how is it administered? It is administered intrathecally. And what will be the dosage? That is 12 milligrams every 14 days. Right, 12 milligrams every 14 days for 3 doses. Right, for 3 doses. Then once a day, once after 30-day interval, then once every 4 months. Okay, 12 milligrams every 14 days. That means once in 14 days, you should give 3 doses. Then once after a 30-day interval, then once every 4 months. That will be the dosage schedule of the nusinersen, which is a new molecule for the spinal muscular atrophy. And we also have the gene therapy for spinal muscular atrophy. And that gene therapy should be given through intravenous delivery, right? And that is by using a gene from a viral vector. And what is that viral vector which is used for the gene therapy? That is onacimino gene AB parvo vec. That will be the viral vector which is being used for the treatment of the gene therapy of the SMA, that is spinomuscular atrophy. Then how will be the prognosis in these individuals of motor neuron disease? 50% of patients, they die within 3 years. Right, they die within 3 years. Okay, and once they develop the bulbar palsy, right, once they develop the bulbar palsy, the usual duration of survival is about 2 years if they develop bulbar palsy. And if they develop amyotrophic lateral sclerosis, only amyotrophic lateral sclerosis, the survival is around 4 to 5 years. And if it is like primary muscular atrophy or progressive muscular atrophy, the survival will be around 8 to 10 years. Right, the survival will be around 8 to 10 years. Okay, and when the individual has progressed to a severe disease, the final state consists of anarthria, right? So the final state consists of anarthria, right? What is anarthria? That is severe dysarthria resulting in speechlessness, right? Severe dysarthria resulting in speechlessness. And the final state, there will be aphasia, that is complete inability to swallow, right? Complete inability to swallow. And widespread limb weakness. Right, widespread limb weakness. So this will be the final state of these patients with the motor neuron disease. Okay, and ultimately they die of the respiratory failure. So if you take the essentials of diagnosis, these individuals, they have motor weakness. There is no sensory loss or sphincter disturbance, and it is the disorder with progressive course, and no identifiable underlying cause other than genetic basis in familial cases. That is about the motor neuron disease. And we have three forms of motor neuron disease. That is amyotrophic lateral sclerosis, where there is involvement of both upper and lower motor neuron. Then followed by that, we have spinomuscular atrophy, where there is involvement of only lower motor neuron. Then we have primary lateral sclerosis, where there is involvement of only upper motor neuron. Then if you see a clinical scenario here, a 66-year-old woman complains of stiffness and weakness in climbing the chairs. She has history of hypertension and diet control, type 2 diabetes mellitus. On examination, there is mild upper arm weakness, hip flexion is 4/5 bilaterally, and bilateral wasting and flickering of fasciculations in the right quadriceps. Knee extension is 4/5, and brisk knee and ankle reflexes are elicited, as well as the positive Hoffman's and Babinski sign. Sensory examination and cranial nerves are normal, right? And her pulse is regular and blood pressure is 178/97. What is the most likely diagnosis in this patient? So if you observe this patient, the patient has only motor manifestations, right? And the cranial nerve examination is normal, and even sensory examination is also normal. And what motor manifestations are there? That is both upper motor neuron and as well as the lower motor neuron manifestations. You take the stiffness, that will be upper motor neuron manifestation. Brisk knee and as well as ankle jerk, that will be upper motor neuron manifestation. And positive Hoffman's and as well as Babinski, that is also an upper motor neuron manifestations. Then you take the presence of fasciculations, that will be the lower motor neuron manifestations, right? So the individual has both upper motor neuron and lower motor neuron manifestations. So what will be the answer? That will be the amyotrophic lateral sclerosis, right? Amyotrophic lateral sclerosis. So this is how a presentation of a patients with motor neuron diseases will be, right? So with this, I'll wind up this session. Thank you very much.